Am I good to share my screen?
Please.
Oh, before Madison starts, hello everyone. Dr. Ashrati here.
All right, sir.
Yes, I just wanted to students and residents presenting today. And I want to thank you, all of you, for giving the opportunity to all our medical students and residents. We are so proud of this organization at Ochsner and want to make sure that every year, like last year and like in the future years, we want to participate and be part of this wonderful society.
Thank you for that. Thanks for being a part of it too.
Absolutely. It's our pleasure. All right, Madison, sorry for interruption. You can go ahead.
All good. So I'll go ahead and get started. So this is a case review on a Percival sutureless valve, and it's entitled Percival on the Loose. It's an intraoperative dislocation of a sutureless aortic valve during a redo double valve replacement. And these are my co-authors. So just as an introduction, our patient was a 78-year-old man. He had presented for a redo aortic valve replacement due to complications from endocarditis. His previous aortic valve replacement was 14 years prior for aortic stenosis. His blood cultures were positive for strep bovis, and the initial echo did demonstrate severe mitral regurg and aortic insufficiency. He did initially complete 8 weeks of antibiotic treatment and then presented to the OR for mitral valve replacement with a traditional bioprosthetic valve, and then an aortic valve replacement with the Percival valve, which is kind of pictured to the right here in a kind of cartoon view. It is a balloon expanding stented sutureless aortic valve, and it's emerged as like an alternative to traditional surgical aortic valve replacements. It comes in 4 sizes: small, medium, large, and extra large, and those correspond to those valve diameters listed there. So once the patient was induced with general anesthesia, the intraoperative transesophageal echo did reveal that previous bioprosthetic valve in place in that aortic position with the severe aortic stenosis and aortic insufficiency. And the aortic insufficiency was noted to be entirely transvalvular. The bioprosthetic aortic valve was well seated. There was no signs of paravalvular leak. And then looking at the mitral valve, there was evidence of severe mitral regurgitation due to leaflet destruction, including a flail A3 segment and perforation of the anterior leaflet. And here is a view of the mid-esophageal aortic valve in the long axis view, demonstrating those findings. So once intraoperative, the surgeons measured the aortic annulus to sinotubular junction ratio to be 1.3. And this measurement in particular is pretty important for the Percival valve because it has to do with like the landing zone for the valve. With it being like sutureless, it's quite important that it's sized correctly. If it's too large, you could get like crimping of the artificial valve, and that could lead to central aortic insufficiency or rupture of the artificial valve. Additionally, if the valve is sized too small, which was likely the case in this scenario, it can result in migration. The mitral valve annulus was sized to a 31 millimeter valve. They chose the Medtronic Mosaic porcine bioprosthetic valve, and then the aortic valve annulus was sized to an extra large Percival valve, which corresponds to 27 millimeters. And it was during the when they were trying to separate from cardiopulmonary bypass that they noticed that the Percival valve was in an unstable rocking motion. And you can see that on the echo here, again, in the aortic valve long axis view, mid-esophageal. And that second part actually showing the full displacement of the Percival valve. It became like freely mobile in the aortic root and the ascending portion of the aorta. So our case was complicated by the fact that this was a redo aortic valve replacement. Additionally, because the patient had presented with endocarditis, there was possible anatomic changes related to that. And then additionally, there was extensive tissue destruction of his native mitral valve. So they ended up having to do like a concomitant surgery with both valves needing to be replaced. And looking at prior studies just to see like what's kind of occurred in the past to compare that to our particular study, many times have the aortic valve has been replaced with the Percival with a concomitant mitral valve replacement that's effective and reproducible. Additionally, using the Percival in redo aortic valves for endocarditis, also done pretty frequently. One thing that we did see was a case report on a Percival valve dislocation in another double valve replacement, but they attributed this displacement due to increased traction on the aortic valve during placement of the mitral valve bioprosthesis. But this was kind of opposite to the order that this surgery was completed. So couldn't really be the case for this because they did the mitral valve first. So it wasn't like the traction could have caused the dislocation. And then there was also a case where the Percival, the valve itself, displaced 24 hours post-op, and they were able to do like a valve and valve TAVR to kind of fix that, as opposed to having to reopen the patient. And then there was also a case study of a Percival being dislocated 22 months post-operatively, and they did have to go back in and redo that valve replacement. But of note, this patient did have a congenital bicuspid aortic valve. So overall, in mild cases, if there's a small paravalvular leak around the Percival, you can reposition or reinflate the valve if it's small enough. And it was really critical that TEE was being used intraoperatively so that the aortic insufficiency and paravalvular leaks could be readily seen. And these are best seen with mid-esophageal aortic valve long and short axis views. And then just wanted to include some of the midterm outcome data for the Percival valve and how that's really promising, mortality being 5-year mortality being comparable to surgical aortic valve replacement, low incidence of the paravalvular leaks at 5 and 11 years, and then just overall mortality being pretty low for those patients as well. Sorry if I went over time a little bit.
You're entertaining questions? Any questions on this presentation? Were you happen to be there during this surgical procedure?
No, I was not there. This was back in like 2018.
Oh, okay.
Yeah.
All right. Because, I guess Dr. Kasarek was driving the transesophageal echocardiography probe.
Correct. Yes.
And so this is a classic or wonderful example of how the anesthesiologist using advanced tool sets can improve the outcome for a patient. Decades ago, when I was in the cardiac rooms, we didn't have echo. In fact, it was just still on the research bench being developed, and it would have been very, very difficult to pick this up intraoperatively other than just failure of the heart during wean from cardiopulmonary bypass. I've even regretfully had to use an echo to help in a myocardial death during laparoscopic cholecystectomy, in which we couldn't figure out why the patient suddenly flatlined on us. And it was very instrumental in dropping the probe in and allowing us to help make a diagnosis in this patient. Regretfully, we were unsuccessful. Be that as it may, it's a specialty tool that's being used for the newest generation of anesthesiologists. And that's how, in the opening remarks, how we drive the science of our specialty. And these are tools that you will learn and become conversant with during the course of your training.
And real quick, Dr. Osman, Madison, what was the blood pressure prior to this valve dislocation and then immediately after? Do you happen to know what the?
I do not. I'll be
Right.
honest.
Just curious if we had some elevated pressures at the time of this deployment, or certainly some low ones I would expect, or lower after the deployment there. But okay,
Yeah, that
just
would be
quick.
interesting to look at. Yeah.
Well, certainly this is the time in which to make the discovery so that you can correct or reseat the valve rather than the patient experiencing hypertensive episodes in a less monitored environment in which such tools would not be readily available to allow quick diagnosis and or therapy. Any other questions? Excellent presentation. Really starts off our meeting on a interesting note. I think our next presentation is Dr. student Dr. Alexander Van Erp. Let's rock and roll.
All right. Thanks, Dr. Nossman, and thanks, Madison, for getting us started.
Yes.
All right. Can you guys see my slideshow? Awesome.
Yes.
Okay, so my project was done in the critical care anesthesiology department at Ochsner Health. We looked at the initial pulse oximetry readings for patients suspicious for COVID-19 and whether or not they're a predictor for hospital death. So starting with some background information on why this is important. There's strong literature showing that early recognition of patient deterioration is the primary successful determinant in medical intervention. In addition, recognition of patient deterioration requires concrete values that can be used to guide timely decision-making. Timely decision-making is crucial because there's extensive literature showing that tissue hypoxia can cause death in stress load conditions. So our objective with this project was to investigate the ability of pulse oximetry to predict patient deterioration in COVID-19 patients. Then in turn, we wanted to see if there was a certain pulse oximetry level that could be used as a trigger point for therapies that prevent deterioration in COVID-19 patients. So following IRB approval, 121 consecutive COVID-19 ICU patients 18 years and older were reviewed for their initial vital signs, including pulse oximetry, during their ED admission that led to transfer to the COVID ICU. These values underwent multivariable and recursive partitioning analyses for association with hospital mortality. Probability values for all the frequentist tests were set at less than 0.005 for statistical significance to minimize the risk of false discoveries. So getting into some results, when we looked at the vital signs, of all the vital signs, only pulse oximetry was statistically associated with hospital mortality, with a chi-squared of 8.1 and only a 0.0045 probability that the chi-square is due to chance. And then looking at this in graph form, we see the relationship of hospital mortality to initial pulse oximetry readings. There's a progressive increase in hospital mortality as we go to the left with decreasing initial pulse oximetry values. And then getting into the most important part here. So now that we know that decreased initial pulse oximetry readings are associated with higher probability of hospital mortality for COVID ICU patients, we needed to find out how low the pulse oximetry levels had to be predictive of hospital mortality. So we're working on making this a little bit more user-friendly, but I'll walk you through it. In the top box here, we see that in this study of 121 patients, the overall hospital mortality rate was 27 out of 121 of the patients, or 22.3%. These patients are represented here in the red. The survival group was 94 of 121 patients, or 77.7%, and that group is represented here in the blue. So we use recursive partitioning to create cut points in the data for initial pulse oximetry ratings. Put simply, we tried to find the oxygen saturation level that created the biggest divide in hospital mortality between patients above that level and below that level. We found that a cut point of 88% identified two groups at different risk for hospital mortality. When initial pulse oximetry values were greater than 88%, as seen in this group on the left here, which has 69 patients, the incidence of hospital mortality decreased all the way to 10.1%. On the right, this group with 52 patients with initial pulse oximetry readings below 88% are shown here. For this group, the incidence of hospital mortality increased to 38.5%. So clearly, at initial oxygen saturation levels of 88%, we see a clear divide in hospital mortality between the two groups. So now the question is, how can we use this information? We know that early recognition of patient deterioration is the primary successful determinant in medical intervention. And we know, as discussed earlier, that recognition of deterioration requires concrete values that can be used to guide timely decision-making. Our results suggest that an initial pulse oximetry value of 88% could be used to identify COVID-19 patients at a high risk of deterioration and potentially guide medical decision-making as a trigger point for therapies that are shown to prevent deterioration in COVID-19 patients. All right, any questions?
So you set your statistical significance to now a much smaller value, 0.005. Why did you do that?
Am I on mute? Oh, okay. To make sure that we had a strong correlation and didn't find any false positive results.
Okay. So these false discovery rates, what do you mean when you say false discovery?
So if we found something that we thought was associated with it, but we set the bar too low and found an association that really wasn't that strong, because you need a really strong association to back your decision making.
Okay. How many times have you been in the operating room and you've seen the pulse oximeter signal less than 88%?
I don't know if I could count it. I think a few times in my 8 weeks of.
Okay, so in 8 weeks, you've seen it more than once. And how did the patients that had low saturations, how did they fare? Did they die, or did they were they brain dead, or?
No, they ended up all right.
Oh, okay. So yet in your patient population, we had patients that came in at the very beginning with pulse oximeter values, according to your work, less than 88%. We're experiencing a relatively high mortality rate, 38%. Why? What's the difference?
You mean that the fact that they have COVID? And
well, yeah, they had COVID, but a lot of patients come in sick to a hospital. Would you not agree?
oh, are you saying because in the OR there's a lot of resources available and there's close monitoring, and so it's a very controlled environment?
Well, your premise was you were looking for stress load. And so we routinely see pulse oximetry values drop, especially if there are young doctors or doctors to be trying to put in breathing tubes in patients, yet invariably the patient recovers. And that's because they're not truly under a stress load condition. Now, everybody else in the room gets stressed out, but thank goodness the patient doesn't. Okay. And that's largely because there's plenty of oxygen stored in the body. There's more than just hemoglobin storing oxygen. There's other globins that store oxygen in the body, and that's the reserve from which cells can obtain necessary oxygen for oxidation purposes. And so you identified in your patient population patients coming in under stress load conditions seeking help, and starting to show signs of deterioration, i.e. their pulse oximetry values were starting to regretfully go down. And this was the initial values before any therapy had started with these patients. And so with that finding that we have patients that come in to the ED and they have these values of less than 88%, what would that tell you to tell your ED colleagues in taking care of these patients?
That we could initiate therapies such as like remdesivir or dexamethasone or other therapies that could be shown to prevent their deterioration and hospital mortality.
There you go. So that if we have this marker, this herald says, hey, we need to start our medical therapy on this patient in the ED now. That's the goal, is to identify patients that are truly in trouble and that need supportive care now.
Mm-hmm.
And see if we can make a difference.
I'd like to say that it's interesting that the initial observation of many ICU physicians and pulmonologists was that in COVID, patients came in with remarkably low saturations, unexpectedly low saturations compared to other pneumonias that they'd in clinically seen. I'm wondering whether there have been any studies like this that have been done on that you know of, that have been done on, for instance, pneumonia due to influenza or pneumonia due to parainfluenza or other viruses?
That's a great question. I'm not aware of anything like that. Dr. Nossman, have you looked into that at all?
I only know of one study, the one I'm hearing tonight.
Oh.
So, and I would ask Alexander the same thing. If just to forward Dr. Nossman's point, how many times in recovery room have you seen a saturation of 88%? Have you seen that more in recovery room than anywhere else?
Less than the OR.
Really? Okay.
But
and would you think that was an indicator of foreboding events afterwards, or with an 88% recovery? How would you read an 88% recovery room? All comers.
I would probably first, you mean it systemic wise? I would say like there could be just an issue with the pulse ox first, especially in the recovery move where the patient's moving around.
Tap the patient and tell them to take a deep breath. That's most of the time what we've got to do there. And that we would not, none of us would be too concerned with an 88% recovery room unless A, the monitor wasn't going off, or B, the patient was in their progression down. You know, and you think about oxyhemoglobin dissociation curve and where that break is, think about what your study showed too. So I think that's the point, to Dr. Nossman's point, is that these people are already starting at this place. They don't have respiratory depressants on board. They're walking in and going, hey, I got an 88%. That's pretty dramatic, actually.
Mm-hmm.
Good job. Thank you.
Thank you. Thanks everyone for listening.
All right, I think it's my turn.
All right, I think we'll have student Dr. Christian Lee. He's our third presenter tonight.
I'll try not to stir up Dr. Kowaleski on this one.
Well, it's always good to bring those who are in the shadows into the light.
After the
This might be stirred out.
is this in?
Go ahead and click your slideshow at the top too and get you. There you go.
Yeah, sorry, I put it on my other screen. I don't know why. Okay, so Dr. Nossman and I started this project, the analysis of neuromuscular blocking agent reversal at Ochsner Health, just to sort of see what we could find at Ochsner in regards to Sugammadex versus anti-muscarinics like neostigmine. So we compared Sugammadex use to neostigmine in multiple hospitals throughout the Ochsner healthcare system. I didn't put it in this slideshow, but we have one from West Bank, Shreveport, all around the state to gain enough data to see real results for Sugammadex use. So the purpose was really that comparison. And we were trying to see the end of procedure to out of OR time intervals and how these different medications change those time intervals. We found that this was a very accurate measurement, as anesthesiologists are dealing with the recovery of the patient. You have other people in the OR that were recording these OR times. So they were the most accurate readings that we could find. We also wanted to compare the use of these medications in a very common procedure. We chose laparoscopic cholecystectomies because they are one of the most common procedures in the state of Louisiana. Especially with our population, we see these very frequently. So our methods, like I said before, we compared these medication uses in lap chole procedures throughout the state. We chose a 1-year time period between May 18 to May 17, 2021. We used any participants that were over the age of 18 years old scheduled for these laparoscopic cholecystectomies that underwent general anesthesia with the NMBA reversal agents. So this slide is very busy. Sorry about that. We have a box and whisker plot on the top left here. As you can see, each method of reversal in its own category. It's very hard to tease out any information from this box and whisker plot, so we tried to use a normal quantile plot on the right to see if there was any differences in medication reversals. Right around 0.6, you can start to see some variations in the use, but again, it's very hard to determine if there's any difference in effect. If you turn your attention to this box on the bottom here, you can see in numbers basically our findings of this study. You can see the median end of procedure to out of OR times for Sugammadex was 9 minutes, with an interquartile range of 6 to 12 minutes, with a maximum of 72 minutes. And then if you look at neostigmine, the median end of procedure to out of OR time was 8 minutes, with an interquartile range of 6 to 11 minutes, which is slightly lower than the Sugammadex use. We also have a combined reversal group that has a median range of 12 minutes with an interquartile range of 8 to 18 minutes. We did show that based on our chi-square plot that this was significant data. The probability due to chance was 1 in 10,000. So our data did show that we observed very minimal change in the use of neostigmine or Sugammadex for reversal in these lap chole procedures. And then here are some of our main observations. We had other parts to this study that I didn't include in this. It would have taken a lot longer, but this was one of our main points that we studied. So overall, the median OR exit times were less than 10 minutes overall in the cohort of 1,800 patients. 50% of them ranged from 5 to 9 minutes. That was by 803 patients. And then about 10% of these cases that were using neostigmine required some sort of Sugammadex assistance for the reversal. We did notice that Sugammadex for the rescue of RNMB following neostigmine administration was beneficial in that 10% of patients. There was also an increase in PACU recovery times with the use of Sugammadex, and we thought that this might have been a surrogate marker for the procedure times. Longer procedures needing certain reversals needed that aid of Sugammadex. Okay. So another main observation that we saw was that the use of Sugammadex as the primary reversal agent did not provide the time savings in this cohort with this particular surgical procedure. Initially, I went into this study talking to Dr. Nossman, assuming that we would see some significant time-saving effects with the use of Sugammadex, especially for this large patient population. The second part of the study was going to be an analysis or an economic analysis of how much money could be saved by using Sugammadex, but that wasn't able to occur because we didn't see a significant time savings with the use of Sugammadex. Any questions?
So I'll jump in with the easiest question. Did you look at cis-atracurium reversal with Sugammadex?
We did not.
Okay, why is that?
I think the main ones that we saw that were used in the Austrian healthcare system was rocuronium and vecuronium, but it wasn't.
It's a trick question. I'll stop you because it's a trick question.
Okay.
It doesn't work with cis-atracurium. And the only reason I threw that out there is you'd be surprised how many of our mid-level colleagues don't realize that that's the case. So that was a trick question, unfair to you, Christian. I wouldn't want to go down that path. The other thing I would point out with this is a good highlight of how, when you do a study like this and you're looking at cost and time, if you'd have found something very differently, it's very difficult to convince pharmacy heads, hospital heads, system heads about the big picture savings that can occur. They are used to looking into silos and say, this drug costs this much. So we have to be smart of that and prove if there's a medication that we think will decrease time in the hospital, decrease time in recovery, decrease time in the OR, and get them out of the OR, we have to make that case. And those of us a little more senior in this call have probably made that case for many drugs over many years and decades for some of us. And you just have to outthink folks to get what you need for the right care of the patient. So I think you were heading down that with this study, and it may not have shown what you wanted to, but had it done that, it would have been a great example. And that comes from silo cost centers in healthcare, not looking at the big picture of this. So just keep that in mind and don't get trapped in that cis-atracurium thing again.
Yeah, well, I definitely won't. And that was a few of the, I guess, the shortcomings of this study was that we looked at only one procedure, and we looked at the patient population that typically gets this procedure. So there could be cost savings in other procedures where Sugammadex is used more frequently, and then you would have to do other research projects for those surgeries.
And just in case no one else has a question, I'll give you one simple example that points fingers at insurance company and cost. In around 2004, Blue Cross sent letters out to many of us physicians and said they were no longer going to pay for peripheral nerve blocks. In 2004, it wasn't as prevalent as it is now. Catheters weren't as prevalent. My group was certainly doing it on every patient that could get a nerve block. And they, in that letter, pointed out what the cost of morphine was. So it's one of those letters that I wish I still had somewhere rather than tearing it into shreds. We got patients and others to get involved, and we got Blue Cross back to paying for that because it does cost on paper for a nerve block, a kit, the physician that knows how to do it, and the maintenance afterwards. And yes, that cost is probably more than a 2, 4, and 10 milligram vial of morphine, but you have to make that case. I just wish I'd have saved that letter.
Dr. Kowaleski had his hand raised.
Yes. Hey, I find the results very surprising and counterintuitive to my experience in the OR. And so I have to wonder if the measured out or the measurement that you made, time from end of procedure to out of the OR, is that a relevant measure? I wonder, if you're planning to use Sugammadex, I imagine that the patients that got Sugammadex, the anesthesia care team planned to give them Sugammadex, and did they then perhaps use different doses of steroid-based muscle relaxants? Those would be Christian, vecuronium, and rocuronium currently on the market, and or was the dosing different? Did they wait to give the reversal a different amount of time? Did they realize that it doesn't matter how long you take to get them reversible or reversed. It doesn't matter when they're reversed as to how many minutes you're going to be till you leave the OR, because there's other things happening. You still have to move the patient to the gurney. The nurse has to do whatever the nurse has to do. And, you know, is that a fair marker of that it's trying to see if Sugammadex versus neostigmine has a difference in outcome? I still suggest that, you know, again, I said counterintuitive. To me, Sugammadex is a wonder drug. When I think there's few things in medicine and science, clinical science, clinical medicine, where you see such a dramatic difference. And the first couple times I saw Sugammadex used, that was one of them. I said, this is different. This is unbelievably different than many other things. Propofol versus Panathol, who cares? Isoflurane, sevoflurane, not that impressive either. Actually, desflurane, pretty impressive in my opinion, although others disagree. But Sugammadex, I think, is very impressive in the OR. So I don't know why we can't measure, why we can't prove to the bean counters that it is worth the additional initial expense to buy the bottle from the drug company. Thank you. To your good point, study.
That's the reason why I worked with Nosman to create this study. That's what I assumed, you know, would show up. And initially, this was only the first half of it. So we assumed that there was going to be a time saving that we could, you know, show economic value with. And it was kind of surprising to both of us that didn't occur. And then to your other point about it being an accurate measure, I mean, we assume that there's, you know, a standard of care that these drugs are given, you know, when the physicians deem them necessary. So we just assumed, again, that would be an accurate measure. But we also did show that, or we observed that Sugammadex had an increased PACU recovery time. So, I mean, again, there could be confounders, there could be other things that we need to research, but I mean, that's just the I guess the basic data that we harvested.
So what if you were to redesign this study, did you find any clues? Do you have any intuition? How could you do the study, next study, and maybe see a difference?
Yeah, I just from my perspective, I think Dr. Nosman might have another perspective, but maybe if we see exactly when these drugs were given, not exactly end of procedure, but if you have a reversal agent that's given, you know, 20 minutes before the end of procedure versus one that's given 5 minutes before, that could change your numbers a little bit. I don't know. We would have to standardize when these medications are given, and I think that would have to be something that we would do in the next study.
Well, the problem is when you start doing standardizations and you've got the searchlights on the person doing the case, that's an example of the Hawthorne effect. Hawthorne effect says there's always an improvement in times.
Yeah, observation changes results.
There you go. And so the purpose of this is we all have had experiences with Sugammadex. It is a remarkable reversal that's really independent of depth of train of four compared to neostigmine, where we would get in trouble if we gave full reversal with a very intense rocuronium block that frequently occurs in laparoscopic procedures, because you can get a little bit better operating room conditions for the surgeons when you do laparoscopic surgeries. And of course, when they're working on laparoscopic cholecystectomies, you're actually working up into the patient, and you've got them positioned head down, etc. And so you're maximizing the abdominal wall relaxation. But when the case is over, you're waking the patient up. You're doing the reversal etc. And so we just translated all of this noise, like Dr. Kovalevsky said. They're doing this and that and the other. And when you're busy taking care of the patient, you may not be clicking the buttons exactly on the electronic medical records, whereas you're more likely to have the circulator clicking the buttons. Certainly, end of procedure, click, out of the room, click. And these are Association of Medical Operating Room Directors defined times. This is also known as the OR discharge time, in which you would have hoped that this rapid reversal would translate to time savings of a few minutes to warrant a use of this drug and have less residual neuromuscular blockade, as evidenced, which we didn't really see indirectly in our PACU times. And so this was a fascinating, eye-opening study. And yes, you're quite right that we could look at this with other procedures, but lap choles now are down to a very quick operation, and that we want to see if there's a rapid turnover. Certainly our next group that we're going to look at is laparoscopic bariatric surgeries, and see if that makes a difference, because there you're dealing with a more difficult airway patient population in general, and you want to make sure you have the lowest percent of residual neuromuscular blockade, and you would have a measurement of that by successful oral tracheal extubation in short recovery room times. This was a fun study, 1,800 patients. Now, one of the problems that we had was the accuracy of the electronic data harvest. You want to go through that, Mr. Lee?
Sure. So our initial harvest, when we did the 1,800 patients, we saw that, or actually I saw when I went through them individually, that 12% of, or I guess 86% was accurate. So we did notice that the actual harvest through slicer dicer wasn't accurate to our parameters. And I had to go through each
1,800 records.
Yeah, to make sure that they were right. So
yeah, and we reported that to one of our Epic colleagues, and he was distressed.
he said you could have talked. He said you could have called me and you could have not done that, but I was like,
so it was just we're just kind of letting people in charge of Epic know that their product is not as sound as we had hoped it would be. Be that as it may, we made the corrections. We presented, I think, a fascinating study tonight, and it certainly has generated beaucoup questions.
Bobby, you're not suggesting that electronic medical records aren't perfect, are you? That's
no, you would think that they would be would be more accurate than handwritten records, which are very difficult to read. And we have now, evolved away from that. So we still have a lot to go forward in recording accurate times and measurements, etc. Because GIGO, garbage in, garbage out.
Amen.
We want to be able to, we have the wherewithal to understand these complex concepts, and that helps us improve patient care, helps improve patient satisfaction. The surgeons are happy, and if they can be, and it's a win-win-win for the specialty. All right. We'll now go to Shreveport for Dr. James McDonald. Thank you, Christian.
He is unable to be with us tonight. So do we want to skip his presentation?
Video for him, or
I think
could we very quickly just look at?
I can play his presentation if you'd like, or we could skip.
oh, okay. Yes. Yes, certainly if you have a video clip, we'll be glad to.
All right, hold on. I need to. Everybody can see that?
Yes.
Year-old African-American female that presented for a mediastinal mass excision. My faculty sponsor is Dr. Shilpa Patil. Our objectives for this case are to present the case of patient with Rosé-Dorfman, understand the features and clinical concerns of patients with Rosé-Dorfman, and understand the anesthetic concerns for patients with this disease. Our patient history, she's a 62-year-old African-American female, BMI of 26, past medical history of Rosé-Dorfman, diagnosed by pathology after a craniotomy. Her surgical history, in addition to this craniotomy, included a hysterectomy with no previous anesthetic issues. She was allergic to citrus and lactase. Her social history was negative, and her family history was positive for liver cancer, uterine cancer, and diabetes. Our patient presented to an outside hospital emergency department with complaints of dizziness, confusion, and headaches. She then received an MRI brain that showed a left frontal extraaxial mass. A month later, she received a left craniotomy with resection of this mass, and pathology showed findings suggestive of Rosé-Dorfman disease. She was then referred to our hematology and oncology service, where a PET scan and CT chest revealed a right-sided mediastinal mass that was not amenable to CT-guided aspiration or biopsy, so she was then referred to our cardiothoracic surgery service. They then decided to plan for a robotic excision of this right mediastinal mass. Some imaging that this patient received, this is the CT chest and the PET scan, both with arrows showing where this right-sided mediastinal mass were located. Our anesthetic plan was to perform general endotracheal anesthesia with a 37 French left-sided double lumen tube that we placed with a McGrath 3 laryngoscope. That placement was confirmed and then corrected with a fiber optic scope. We did a pre-induction radial arterial line, a right internal jugular 7 French central line. The patient was then positioned in the left lateral decubitus position for the operation. She was maintained with isoflurane. We performed one lung ventilation with the right lung being down, and then she was successfully extubated at the conclusion with no issue. She had no anesthesia complications and no surgical issues postoperatively. Some discussion said that what they found was a globular mass sitting in the mediastinum, anterior to the phrenic nerve and adjacent to the pericardium. The pathology revealed abundant histiocytes, plasma cells, and small lymphocytes. These histiocytes were enlarged and actually contained intracytoplasmic lymphocytes engulfed within them. They did some immunohistochemical staining that we'll discuss later, and the morphology and the immunostaining pattern was consistent with Rosé-Dorfman disease. So a little bit about this disease. It's a rare histiocytic disorder described by Rosé and Dorfman in 1969, called sinus histiocytosis of massive lymphadenopathy, classically presented with bilateral painless cervical lymphadenopathy, fever, weight loss, and night sweats. It can be found in other regions where lymph nodes are present, including inguinal, retroperitoneal, and mediastinal lymph nodes. There's also an extranodal component to over 48% of the cases. It has an unknown cause. It's diagnosed by biopsy of the affected tissues, and microscopic examination show histiocytes with intracytoplasmic inclusions of other cell lines, including lymphocytes. The staining pattern for it is positive for S100, CD68, and CD163, and negative for CD1A. This is a schematic just showing that it's enlarged histiocytes within these lymph nodes and that they have these intracytoplasmic inclusions of these other cell lines. So anesthetic considerations for patients with this disease are mainly due to where the involvement is in the procedure to either biopsy or resect these nodes or this extranodal component. For ours, it was a mediastinal procedure. So our major goal is to assess the risk of airway or respiratory compromise with a mass effect possible on the airway and lungs, mass effect on major cardiovascular structures and circulation, and possible adverse consequences of the induction due to loss to an awake patient's compensatory mechanisms. She also has a risk for consequences of surgical manipulation and resection of the mass. In conclusion, Rosé-Dorfman is a rare histiocytic disorder characterized by lymphadenopathy and extranodal involvement, diagnosed by biopsy and immunohistopathological staining. An anesthetic measurement is based off the location of the target lesions. Thank you for your time.
Okay.
Any discussion?
I have to say, I had no clue what Rosé-Dorfman syndrome was.
I'm in agreement. Thank goodness you have a CAT scan to determine if there's any airway compromise, which if you've ever had that issue before, you'll never forget it again. Never forget it.
That's a fact. And I was just going to point out, Bobby, that sometimes these patients, you can't get a double lumen endotracheal tube down. So these large compression patients, you end up doing awake fiber optic intubation just to maintain ventilation. You have to deal with a reinforced large endotracheal tube. And now we've got so many different great bronchial blockers. That's what I've used in most of these cases, because that trachea, especially distally, can be really small in some of these masses.
Yes. And the beauty of the endobronchial blockers is that you can actually use it to insufflate oxygen past the mask if you get into issues with oxygenation of the patient. It's an excellent rescue. Let's go on to Mr. Joseph Queen and his presentation.
All right. Thank you, Dr. Nossman. I'm going to try and share this.
I guess I assume you're selecting the
I'm
share
trying to-
screen, but
Yeah, I'm trying to unlock like the preferences. Computer, like sharing the screen. I may have to reopen my Zoom.
okay. Why don't we go to the next presenter and we'll come back to you, Joseph, okay?
Okay.
Let's see. Next will be the last minute procedure cancellation. Oh, have we been, I can't tell you how many times I've had those with Michael Razvi.
Yes,
Razavi?
Razavi. Thank you, Dr.
Thank you, sir. I apologize.
No problem. I'm gonna go ahead and share my screen.
Please. And send a quick email to Joseph how you did it.
Okay, I'll try.
Yes.
Okay, so my name is Michael Razavi. I'm a fourth year medical student at Tulane. I wanted to thank LSA for the opportunity to share this case titled Last Minute Procedure Cancellation and Near Miss Scenario. So surgical procedures canceled or postponed on the day of surgery can lead to significant revenue loss as well as decreased OR efficiency. And there are numerous factors that can lead to procedure cancellation, whether it's individual patient decision, lack of preoperative evaluation, or OR schedule changing. Notably, cancellation can lead to significant emotional and financial stress for patients and their families as well. Here we examine a case of procedure cancellation on the morning of surgery for patient safety. Our patient is a 66-year-old male. He was scheduled for an elective left total knee replacement under spinal anesthesia. He arrived to our preoperative block area for a plan of an adductor canal nerve block. His medical history was hypertension and bilateral knee osteoarthritis. Medical clearance report from his primary physician noted an unspecified murmur. However, unfortunately, there was no other supporting information with this report. His significant surgical history was an urgent right total knee revision 3 months ago. This was subsequent to removal of infective hardware from his primary right knee replacement. His medications are as listed. On further questioning, the patient denied any chest pain, shortness of breath, or cardiac history. Unfortunately, assessment of true exercise tolerance and functional capacity was hindered since the patient had limited mobility with his knee. Upon undergoing diligent physical exam by the anesthesiology team, he was found to have a grade 4 out of 6 harsh systolic ejection murmur. We were able to obtain outside medical records less than an hour before surgery. It's important to note that these records were over a year old and they were done prior to his previous surgery. They noted aortic stenosis, a 4.7 centimeter aneurysmal dilation of the ascending aorta, and an EF of 60%. The records also revealed that the patient was instructed to follow up after his initial surgery with his cardiologist, but he had not done so. It's also important to note that his cardiologist is in one system, his primary care physician is in another system, and his orthopedic, surgery, and anesthesiology team were in a third medical system, which made it challenging to coordinate care and obtain records in a timely fashion. On the basis of this newly obtained information, the decision was made to postpone the elective surgery until further evaluation of the patient's aortic valve could take place. The decision by a patient's anesthesiologist to cancel surgery even at the last minute was not easy, but it was not without significant rationale. Ideally, this patient's medical issues with his valve would have been discovered well before the day of surgery, allowing him to be appropriately risk stratified and optimized prior to the procedure. That being said, it is likely our patient was cleared under the pretense of being fine with surgery 3 months ago and being pushed through the preoperative screening process. This likely had a snowball effect throughout that process, leading to our scenario. Though the intraoperative hemodynamic goals for aortic stenosis could have been achieved, the risk outweighed the benefits, and patient safety in the perioperative period was paramount for us, and the decision was made to cancel the case. Talking a little more about his aortic stenosis and neuroaxial anesthesia. So neuroaxial anesthetics have potent sympatholytic effects, and this compounded with the pathophysiology of aortic stenosis could result in exaggerated decrease in coronary artery perfusion pressure. Thus, the current plan for our patient to undergo spinal anesthesia placed him at increased risk for perioperative myocardial ischemia or even infarction. Furthermore, in the rare event our patient experienced intraoperative cardiac arrest, CPR would prove challenging given the reduction in coronary artery perfusion pressure. In conclusion, a complete preoperative evaluation by a physician anesthesiologist is crucial despite clearance status or recent successful surgeries. A careful physical exam and patient evaluation on the day of surgery prevented this near-miss scenario from becoming a potentially adverse event. Furthermore, cross-discipline communication and provider care is vital, especially when caring for patients who receive care in multiple hospital systems. Evidently, surgical case cancellation can be costly to institutions and pose a large opportunity cost to patients and their families. Despite this, patient morbidity and mortality throughout the entire perioperative period is paramount. Thank you.
Thank you. This is up for discussion.
Sure, Michael, how severe was his aortic stenosis?
So In the records we had, it just noted that it was potentially a bicuspid aortic valve, and they just called it severe aortic stenosis. We didn't have any information on the gradient of his aortic stenosis. So that's another factor that complicated it for us.
I think there's a couple points here. Obviously, I was involved in this case, but one of the things that excited me the most is the resident who was about to perform the nerve block. You ready for this? Listen to the patient and perform the physical exam before performing the nerve block. I hope I don't have to repeat that again. This is obviously, anyone who's been with me knows I can hire block jocks all over the place. There are people falling on trees, but we need physicians to know if it's appropriate. And there's nothing worse than doing a nerve block and then finding out you've got to cancel a case. And one of the more difficult things to do is momentum builds towards a surgery. This is a completely elective surgery that in the ideal, this gentleman would have been seen and all the information would have been collected, but not unusual for probably any one of us that's out there, wherever you practice, for these things to happen, unless everything is in one system and you can get everything together. It also points out for me, and I don't want to steal Michael's thunder, or points out to you the worthlessness of a clearance. Nothing upsets me more than a clearance. This gentleman was cleared with an unspecified murmur by his primary care doctor, who didn't have any clue that this was a severe aortic stenosis murmur, that the plan was, according to cardiologist note, that he would be coming back for valve replacement after he got his infection of his previous knee done, but the patient wanted to get his knee. So it puts us in this situation at 7 o'clock in the morning for a 7:30 start of trying to figure this all out, using folks to look into medical systems that we don't have access to and getting last minute records. So it's the importance of being a complete physician for these patients, the importance of having an anesthesiologist, the importance of having us stand up to stop when it needs to be stopped and proceed when it's appropriate. And the patient was very grateful. I've stayed in touch with the patient. Eventually he will come back, but he is in the process of getting his work up for his valve replacement. So hopefully he won't have Madison's situation, but he will have a new valve at some point and a new knee. So to me, that was important. And I appreciate Michael seeing the importance of this case and going ahead and proceeding with this presentation, because this is what we do. This is what we do, and not everybody will stop these cases. You need to have the strength to stand up and do so and do the right thing, because if it's your mom or dad, you'd want that to be done. So thank you.
Thank you, Dr. DeLanza.
I remember about a year ago, Dr. Kovalevsky having a case in which he was instrumental in getting it highly well organized, and there was a delay, no question about it, but it really changed the course of the patient's care. I thought that was a nice introduction, Joe. All right.
Okay, I'll bite. Was that you're thinking of the POCUS?
Yes.
Yeah, so we had just so happened in the department to have acquired half a dozen very beautiful, fancy ultrasound machines. But more importantly, that had the phased array probe that you can do a TTE, a transthoracic echo with, which frankly I had no experience with, but I knew that that was the probe you needed. And therefore you could do a quick bedside echo on a patient. And gosh, I can't even remember what the case was. I think it was an orthopedic case, but I sent the resident that was hanging around to go grab the machine, and then I went off to find a smart person that could do a TTE. And I found them, and we got it all together. And I now remember the orthopedic resident told me, "It's okay. We don't need to worry about that. Dr. So-and-so, the internist, cleared this patient for surgery." and it was actually somewhat similar. There was some very significant potential aortic pathology, aortic valve pathology. And then more concerning to me, there were some symptoms that the patient was telling me about when I, God forbid, asked questions about their current state of health. And to me, it was very concerning. And I could easily put together a picture of somebody with significant cardiac pathology that we would, then go to sleep and kill. But I believe it was a second-year orthopedic resident. He told me, there's no need to delay this case. They were cleared by the family practice doctor or the internal medicine doctor. Anyhow, the end of the story is, and so that orthopedic resident feels justified, was that we did the echo. We saw that everything actually looked pretty good, and we went ahead and proceeded with the case. But I thought it was a win because we were able to use the equipment that we had and know definitively what was going on instead of just saying, it'll be fine. That's all I got.
Okay, Mr. Queen, you will take a shot at share screen, or we'll proceed to the next. Saints be praised. Mr. Queen, floor is yours.
Okay, you guys can see this, right? Perfect.
Yes.
I don't know. Okay, here we go. Sorry about that. Okay, so I'm Joe Queen. I'm a fourth-year medical student at UQ Ochsner, and today I'll be talking about our research in which we analyzed intraoperative thromboelastograms following the introduction of goal-directed coagulation management guidelines during liver transplantation. So a bit of background, end-stage liver disease can present with many systemic complications and affect virtually every organ system in the body. Of note, patients with end-stage liver disease, they can present with profound derangements in their coagulation profiles, including both hypo and hypercoagulable states. In early liver transplants, patients and doctors face significant challenges with bleeding issues and significant hemorrhagic diathesis. This was originally due to poor surgical technique as well as the coagulopathies. Over time, as we've improved our surgical technique, the coagulopathies still remain problematic. In 1969, Groth et al. First established that liver transplants can cause fibrinolysis. They also documented that intraoperative bleeding occurred at the same time as fibrinolysis developed. Fast forward about 20 years, in 1985, Kang et al. Demonstrated that you can look at thromboelastography, which is shown here on the left, is an example of thromboelastogram. But in 1985, Kang showed that you can use these thromboelastograms to monitor intraoperative changes in blood coagulation during liver transplants. So yeah, these are the values of thromboelastograms or TEGs. And an important one to look at here is the Lie30 value. And the Lie30 value represents the rate of clot breakdown. And on the actual thromboelastogram, it'll look like a dip like this. And that is considered fibrinolysis. A Lie30 value greater than 3% is considered fibrinolysis. In 2018, the International Liver Transplant Society proposed guidelines to assist liver transplant centers in managing end-stage liver disease patients. And using these guidelines, we implemented our own version of them, and we implemented this algorithm in all patients who are adult over 18 undergoing liver transplants. So the purpose of this study was to measure our version of these recommendations during liver transplants. Am I missing? Sorry, sorry about this, but it's in a timed loop. So I think it's going through things, but So to speak on the methods, following IRB approval, all adult patients with end-stage liver disease who were undergoing liver transplants were entered into the study. Showed here is a visual representation of the distribution for patient characteristics in both the control and interventional groups. In the top figure, we have our intervention on the x-axis and age and BMI on the y-axis. In the bottom figure, we see the distribution of patient comorbidities with our intervention again on the x-axis and sodium MELD and MELD scores on the y-axis. Thromboelastograms were obtained at 3 standard times, one at the patient's baseline, the second approximately 10 minutes after arterial reperfusion of the donor liver, and the final thromboelastogram occurred at the end of surgery. The presence of fibrinolysis was assessed following post-arterial reperfusion of the donor liver. So in this study of 1,244 patients, 108 patients underwent goal-directed coagulation management therapy, and the incidence of fibrinolysis immediately following liver transplant decreased from 24.5% to less than 1%. This is a risk reduction of 23.5% with a 95% confidence interval. We also conducted chi-squared analysis with a probability value for statistical significance set at a more stringent value of 0.005 to minimize the risk of false discovery rates as well. And what this means is we found the chance of reduction in fibrinolysis to be less than 1 in 10,000 due to chance. So the conclusion, it's a preliminary study and it suggests that there are important clinical improvements in the incidence of fibrinolysis using thromboelastograms following the introduction of these guidelines. Any questions?
Paper's open for discussion.
I wanted to point out, this is Joe Kowaleski, I wanted to point out to the audience that Yugu Kang was the chairman at Tulane in the late 90s. Is that right, Bobby?
Oh, yes. He was, I'll never forget the time that we were taking care of a patient. She was an OB nurse and severe liver disease. And we were struggling with her coagulation during the procedure. He walked in and said, filter her blood. And so I was puzzled with that initially, but basically he said, let's just hook up the Belmont. We'll just start spinning her blood and not the Belmont, I apologize, Cell Saver. And he said, let's spin her blood and that'll help get rid of the toxins that are circulating in her bloodstream at that time. And it saved her life, frankly, saved her life. So never forgot that.
I was just going to say, as a resident in the early 90s and doing those 24 to plus hour liver transplants, the TEG is a pretty magical device, and the technology as to where it's at now compared to 20, I don't know, almost 8 years ago is amazing. So it is a magical device. It really is.
Yes, it's you're quite right. The first came out, there was like about 20 to 30 steps that you had to take in correct order and the correct to make the values clinically relevant. Yeah. And so it's now it's a tremendous improvement. Tremendous improvement.
Agreed.
We'll go forward to I think Beth Wren. She's going to talk. She's presentation number 7. Beth?
Beth could not be here with us tonight, and I do not have her presentation.
Okay, that's all right. We'll proceed on to evaluating chronic use of opioids and COVID-19 survivors. Looking forward to this. Yeah, sure. It's Raji. Floor is yours.
So my project is on evaluating chronic use of opioids in COVID-19 survivors. And yes, Dr. Shraki is the faculty mentor here, and the rest of our team is listed as well. So basically some background information, as everyone knows about the ongoing opioid epidemic in the United States. That's obviously a problem that we have to balance with prescribing opioids. And then the definition for chronic opioid use is defined as using opioids for 3 months or greater, which is usually only indicated for chronic pain conditions, not something that we necessarily want patients to have to require. And then combining that with the now ongoing COVID-19 pandemic, there has been studies that have shown a rise in non-prescription fentanyl use and heroin use. This was based on urine drug test analyses kind of done pre and post like the start of the pandemic back in April of 2020. And the thought process of prescribing opioids with COVID patients has to do with myofascial pain and the deconditioning that these patients often experience while they are in the ICU for extended periods of time. Additionally, another component of the COVID-19 pandemic with opioid use is the increased psychological stress, kind of with isolation and the different precautions that we as a society have had to kind of deal with. And then there's also been a somewhat recent study that was done looking at Veterans Affairs patients and looking at patients that were diagnosed with any type of post-COVID-19 sequelae. And they showed out of these patients that opioid prescriptions were given 9 times more often compared to all other patients. So obviously there is this increase in opioid prescription, particularly once the patient is discharged with COVID-19. So as far as our study objectives, primarily we wanted to look at the incidence of chronic opioid use, so patients meeting that 3-month use following COVID-19 admission with inpatient opioid treatment. So having been treated inpatient and then giving that prescription outpatient. And some secondary objectives we wanted to look at were just the characteristics of these patients. Additionally, we wanted to look at the opioid prescription type and equivalent dosing. And then another important component was to look at telemedicine visits, because this was something, of course it was around, but not quite as prevalent as it became during the COVID-19 pandemic due to like isolation and people, not wanting to come into the hospital or clinics. So we wanted to see if this would play a role in patients continuing getting those opioid prescriptions. So as far as our methods, this was a retrospective chart review of 330 patients, and we used the Ochsner Health COVID-19 databases. The patients were followed 90 days post-discharge to assess for criteria of that chronic opioid use. We used the COVID-19 data sets to do an initial chart review. And then any patients that had outpatient opioid orders, we manually chart checked those to ensure that they met the inclusion criteria listed below based on their hospital admission information and their outpatient opioid medication information. Kind of similar to what Chris brought up in his presentation, like Epic kind of failed us on this. Like we had certain parameters in place and we were just getting a lot of patients that weren't actually meeting our criteria. So for our inclusion criteria listed here, 18 or older, having that positive COVID test on or after March 1st of last year, being hospitalized through March 1st to July 31st. And these were the diagnosis codes that we had used. And we had some trouble with that because early on, we weren't necessarily all using the COVID-19 diagnosis code. It was still pretty new. So trying to capture all of those patients and making sure that they were given opioids while hospitalized and that they were hospitalized for more than 1 day. And then these were our exclusion criteria. Basically, just if they didn't have any respiratory type symptoms, we didn't want to include those patients. And then if they were admitted multiple times or if they had passed during their hospital stay, we excluded those. As far as our results, we've kind of been in the process of, since we went back and manually chart checked those outpatient orders, the numbers went down significantly as far as patients who actually met the chronic opioid use. As you can see in this bottom figure here, it was literally one patient out of the 330 that we could say, met that 3-month mark. And the way that we wanted to represent this to be able to kind of compare it, whether this was statistically significant, was looking at these 2 other papers. So this cirrhosis hospitalizations and then Medicare hospitalizations. We picked these 2 values from these papers because it had to do with medical, like inpatient patients versus like surgical patients, because we didn't think it would be kind of comparable to compare the COVID-19 patients to surgical patients. So that is why we chose those papers in particular, and they were pretty large size. So looking at their incidence of 45.5% developing chronic use and 42.5%, we could demonstrate that that was certainly significantly different from our 0.3%. And this figure 1 is just looking at the distribution of the outpatient opioid medications that we had seen, as far as hydrocodone being most common, and then tramadol being the second most common. And then with the telemedicine visits, we wanted to see kind of the differences, or if there were any differences between those utilizing telemedicine. And it did appear that 37.5% of patients with outpatient opioid prescriptions did utilize telemedicine visits, compared to 28.9% that didn't have outpatient opioid prescriptions. And there was certainly more data, like the characteristics and all that stuff, but these are kind of the highlights of our findings. So overall, with that one individual, 0.3% only developing chronic opioid use, we can say that patients who are admitted for COVID-19 and do require inpatient opioids are certainly at a minimal risk for developing chronic opioid use. We also were able to see that patients with outpatient opioid prescriptions did seem to utilize telemedicine visits more often. And we were able to compare our findings to those 2 larger papers to kind of demonstrate the size of that finding. And I think that was everything.
Thank you, Madison. This paper's up for discussion.
I guess, but I'm just sitting there trying to bite my tongue because, we catch a lot of blame for the opioid epidemic, and some of it is appropriate. This is just highlighting again that I think your last statement, your conclusion is that we didn't see this as much in this as maybe advertised or in the media. And all the medications we use as alternatives to opioids are not necessarily the most benign and safe things as well. So achieving a perfect balance is what we're shooting for here.
Exactly. Dr. Lanzik, I completely agree with your statement. There are some other studies that are kind of like a fit in the same results. If you look at the RAP, and recently there was another study that's published in like a post-knee arthroplasty, like a basically joint replacement, and they didn't see any increase in opioid consumption in the post 3 months. It tells me that if you use opioids in an appropriate place, in an appropriate dose, in an appropriate patients, the
Oops.
That was the cliffhanger.
Wow.
I think so. All right. Madison, are you up again for the peripheral neuropathy? Or is it Kenneth Hunt?
Yeah, that's Kenny.
Kenneth, excuse me. The floor is yours, Ken. Please proceed.
Absolutely. All right. So my name's Kenny Hunt. I'm 4th year student at University of Queensland, Ochsner Clinical School. And I want to thank Dr. Schrage for letting me take on this project and write about it. So the case I'm going to be talking about is one of peripheral neuropathy post SARS-CoV-2 infection. So as an introduction, at the time of this report, there are over 147 million confirmed cases of COVID-19 globally. That's denoted here back in March. And by the end of August of this year, there's over 213 million cases reported globally. Neurologic symptoms are common in this population. They're observed in 30 to 80%, the most common being anosmia, ageusia, headache, dizziness, and encephalopathy. There's also a variety of other neurologic findings that have been described, such as Guillain-Barré syndrome and polyneuropathy. So the case is of a previously healthy 21-year-old female. She presented with severe pain in a glove and stocking distribution 1 week following discharge from inpatient treatment for COVID-19 pneumonia. During this hospitalization, she was not intubated, only received oxygen through nasal prongs. She presented with difficulty ambulating, performing ADLs, and this was secondary to pain. She didn't endorse any weakness, and her respiratory symptoms had completely resolved at this point. On exam, she had allodynia in extremities bilaterally, extending to the wrists and to the ankles, and strength and reflexes were symmetrical and normal throughout. Diagnosed with sensory peripheral polyneuropathy. She was treated with gabapentin and physical therapy with desensitization. The gabapentin was 300 milligrams nightly with a plan to titrate up to 300 milligrams 3 times a day. And that showed some improvement, but it wasn't really until the 2 weeks of physical therapy with desensitization that she made a full functional recovery. Moving on to the discussion. At the time of this report, there are 2 other cases of peripheral neuropathy in the context of COVID-19. The case described by Abdelnour showed weakness, numbness, and ataxia of the lower limbs, and this was actually prior to the onset of respiratory symptoms. The other case was described by Bureau, had numbness, weakness, and paresthesia, and these presented after the respiratory symptoms. Both made a full functional recovery, despite Bureau's case receiving just supportive therapy only, and the case by Abdelnour received full steroids, IVIG, and multimodal pain control. So currently the pathogenesis of peripheral nervous system symptoms associated with COVID-19 really remains unknown. But there are a couple of theories for what may be causing it. Critical illness polyneuropathy being one of them. However, patients who develop this tend to be sicker and have longer hospital stays. One study found that 100% of COVID-19 patients who developed CIP had been intubated and had an average length of stay of 27 days in the hospital. Our patient was not intubated and she had a hospital stay of 5 days. Another possible etiology is Guillain-Barré syndrome. There are reports of pure motor and pure sensory forms. We did not perform a nerve conduction study, CSF analysis, nor spinal MRI. Thus, a pure sensory form of Guillain-Barré syndrome really can't be definitively ruled out. Yet, I think unlikely as the patient presented with immediate onset pain in both the hands and feet without ascending progression of her symptoms, nor loss of deep tendon reflexes. And then dysregulation of the systemic immune response being another possible cause. Really unknown how this leads to peripheral nerve damage, but it's speculated to be related to vasculitis due to endotheliopathy or microthrombi. Clearly, further research needed to substantiate these mechanisms. So in conclusion, there's a growing body of evidence demonstrating COVID-19's impact on the nervous system. Peripheral polyneuropathy is uncommon, but can cause significant morbidity and warrants further investigation to identify both pathogenesis and appropriate treatment. Here are my references. Thank you for listening.
All right, this paper is up for discussion. Again, we're learning more and more about the non-respiratory end organ damage that occurs in this patient population, regretfully. And I thought this was a fascinating case.
And I was just going to say, Dr. Osman, talking to some of my regional colleagues, they are discussing this issue of post-COVID neuropathy in the face of it being exposed a little more after some sort of regional anesthetic. In other words, 2, 3, 4 months afterwards, patients getting nerve blocks and it's sort of revealing an unusual pattern. It's not a lot of it, but there's discussion about is there an adequate period of time after a patient has COVID that peripheral nerve block should be withheld. So I don't know if that's going to bear any fruit, but it's at least being discussed.
Understand.
That's a wonderful concept, Dr. Lantek. I really like that question because your comment means that potentially a lot of these patients, when they get the COVID-19, at least severe form of the COVID-19, we don't know exactly what's the etiology, they get some form of nerve vulnerability or sort of neuropathy that might even like long lasting for several months. And it was in this particular case, it was like so distinct. This was like a young lady in college and very motivated person. And with like a short period of like being hospitalized with no underlying condition, ended up with this neuropathy. Looks like most of the time it's self-limited, which is promising. But definitely looks like that COVID-19 has the potential to, not just by prolonged hospitalization per se, that probably the effect of the virus itself can cause some neuropathic damage.
Scary case.
Yes, it is. Janet, I think you said Jay Shaw is not with us this evening.
Yes, so we have a little change in schedule. Jay Shaw is not here. Our next speaker is had to leave the meeting with an emergency, so the next one is Jeff Chu.
It would be number 12. Yes, number 12. Okay.
Yes.
Jeff, your floor is yours.
I'm here. Let me share my screen. Can everyone see that okay? All right.
Yes.
Hi, my name is Jeff Chu. I'm a CA3 at LSU Shreveport, and I will be presenting a case of spinal stenosis and neuraxial anesthesia that my faculty and I encountered. So my objectives, I wanted to emphasize relative and absolute contraindications for epidural placement or neuraxial in general, describe steps to identify potential complications of epidural placement, and then discuss ways to manage complications of epidural placement. So my case, we had a 76-year-old white male with a past medical history of persistent hypertension, obstructive sleep apnea, chronic low back pain, with findings of a left adrenal incidentuloma and a left iliac artery soft tissue mass, who presented for an open left adrenalectomy, biopsy of a left retroperitoneal mass, and a wedge biopsy of a liver mass. So he had quite a few procedures planned. Our pain service was consulted for the placement of a preoperative epidural for postoperative analgesia. Preoperatively, this patient had no appreciable neurological deficits. He was not taking any anticoagulation. His white blood cell count was 6.2, platelets 264. Otherwise, no new medical history that we found on interview. So a L4, L5 epidural was placed preoperatively without difficulty. This epidural was started intraoperatively near the end, and then the patient was successfully extubated at the end of surgery. There were no unexpected events intraoperatively, and at that time he reported good pain control and was neurovascularly intact when he was dropped off in the ICU. Overnight, apparently he began to experience some weakness in his right foot, which progressed to a loss of sensation in his bilateral feet and eventually bilateral loss of motor function in almost all of his lower extremities when I saw him that next morning. When I performed a physical exam that morning, the epidural sensory level was bilaterally at a T8 level. He had basically no motor strength of his lower extremities and even loss of reflexes. And then a bilateral loss of sensation below the knees. The epidural catheter site was unremarkable. There was no signs of inflammation or pus or anything concerning. So this was obvious. This presentation was obviously very concerning. At that time, the epidural infusion was immediately stopped, and I called the faculty after we confirmed that he had received no form of anticoagulation. His platelets that morning were still unchanged from preoperatively, and he had no clinical signs of coagulopathy. The epidural catheter was removed. A stat MRI was ordered, and while we were rolling that patient down to the MRI, we also called neurosurgery. So if you can see, this image on the right is the patient's actual MRI that we got. And then the formal reading was there was a collapse of disc space at all levels. There's severe facet hypertrophy with disc bulging at multiple levels. And the most important part was there's severe canal and foraminal stenosis all the way from L2 to S1. There was no obvious epidural hematoma formation. Our neurosurgery colleagues, I also reviewed this image, agreed with the findings of the radiologist, and did not recommend any intervention. They theorized that due to the severe stenosis, the local anesthetic probably had a very increased duration and density that was localized to one area. Fortunately for everyone involved, several hours after the epidural was removed, the patient began to recover his motor and sensory function of the lower extremities. And then by that afternoon, he was back to his baseline. So I just wanted to point out a couple of things in the discussion. Spinal stenosis, as with this patient, it was not diagnosed. He only reported a history of chronic low back pain, but he had never went and sought any treatment or diagnosis of this low back pain, as it really didn't bother him. But spinal stenosis can present with any symptoms of discomfort, sometimes sensory loss or weakness that reflects the spinal nerve root involvement. The main hallmark symptom is neurogenic claudication. And then many times the neuro exam is completely normal in these patients. So due to review of previous literature, this population is known to be at an increased for worsening of any pre-existing or the development of new neurological deficits postoperatively compared to the general population without. Epidural injections of any type of fluid have been shown to increase epidural pressures that are also transmitted to the intrathecal space at that same level. Even just a few cc's in that space can be transmitted, can cause pressure to be transmitted into that intrathecal space and push against any surrounding nerves or blood vessels. And any prolonged increases in this epidural or intrathecal pressure may exacerbate any pre-existing pathology and possibly increase the risk of nerve root ischemia. So in conclusion, in many cases, such as with our patient, spinal pathology is unrecognized or undiagnosed just due to patients not being affected by it enough to seek diagnosis or treatment. These patients are at an increased risk of worsening of or development of new deficits after receiving any type of neuraxial anesthesia. And keep in mind, spinal pathology is not an absolute contraindication. It's a relative contraindication to neuraxial anesthesia. So really, each individual patient needs to be examined. And then the presence of multiple neurologic diagnoses also increases the risk of worsening or developing new deficits. So especially in elderly patients who could benefit from neuraxial anesthesia, we should screen them a little more closely to make sure that they don't have any undiagnosed spinal pathology, or we should manage them a little bit more conservatively to help prevent any of these risks. Okay, and that is the end of my presentation.
That's an interesting presentation. This, any comments?
Oh, sorry. Can you, if someone said something, can you repeat that?
Yeah, it was an interesting presentation. Is any comments from the learned professors?
And me? Oh,
yeah.
I think it's great. And I think the key takeaway from this, I say this all the time, there's none of my residents on here, so they'll hear it, is take neurological complaints and calls very, very seriously, because there's a built-in delay from when the patient lets the nurse know or lets a family know or otherwise. And then you're busy and you're tied up and things drag out, and time is neurons in this situation. And you want to act, you want to get your evaluation done, you want to figure out if you need studies, you want to call up the ladder for staff or colleagues to help, or consultations if you need it. And even if you decide, okay, this is probably nothing, every one of these patients gets a very, very thorough follow-up. So if you say, okay, this is not bad, it's the labor epidural patient that feels like they've got a little weakness somewhere, go see that patient, document it, talk to them, and make sure you set an appointment for yourself to go see them again. So it just, time is neurons in these situations. So good presentation.
Yes.
Thank you. And I just wanted to note, especially for the medical students who will probably be starting residency soon, this timeline actually happened over a course of probably a little more than 24 hours. And this patient was seen by multiple different providers. And unfortunately, sometimes when we give or get handoff, when taking care of these patients, things are missed. So it is quite important, especially if something's been happening overnight, to communicate that early. And it's as annoying as it may be to wake up at 2 o'clock in the morning to go see something, you should go physically examine all these patients, because the other outcome of this, if this patient did have an epidural hematoma, could have been disastrous for that family, especially because that technically needs to be intervened in a much shorter interval than when I came on that next day.
Very good points. Very good points.
Well, thank you all.
Thank you, Jeff.
Ms. Voracek, yeah, thank you for being on with us this evening. We had, what, 2 to 3 didn't show. You want to present your work, Erica? Rika? Chance to shine in the sun. All right. I want to thank everyone. Miss Jana, again, thank you very, very much for your putting this together for us this evening. I learned a lot.
Hold on, we have one more presentation.
Oh, I'm sorry.
That's okay. That's okay. It's Jacob Boudreau. He's our last speaker.
I apologize.
Sorry.
Oh, no, no worries, no worries. Let me get this going. All right, I will be quick since it's toward the end of the night. Can everyone see my screen?
No, you take your time. Feel free.
All
Take your time.
right. My name is Jacob Boudreau. I'm an intern at Oxford Medical Center. I'm presenting this tonight in collaboration with one of my colleagues, Sahar Niazi, who sends her warm regards. She can't be here tonight. Tomorrow she's taking a prometric exam. But over the summer, we, before the Delta wave, we were talking about kids going back to schools. How can we best protect them? And the concept of masks was coming up a lot. So for me, I'm an intern. My patients call me Dr. Boudreau. My family calls me Jake. However, one of my favorite names is actually being called Perrin. I have a very, very cute and adorable little niece who's 3 years old. And Sahar was talking with some of her friends and family who have children, and we want to know what is the best way to keep them safe. So we wanted to look at the published literature that talks about mask wearing in kids and to see what the literature out there says. So this is a little dated. It's we did this in July, about the end of July. So let's take a look at let's review the literature on mask wearing among adolescents. So as we know, the World Health Organization, the CDC, they have issued guidance internationally and CDC here in the US that masks are an essential tool that will help reduce the spread of COVID-19 in addition to physical distancing and frequent hand washing. Mostly for children under the age of 12, this is all we have for them. In the United States right now, I believe as of the beginning of October, all 3 vaccines in the US are approved for those 12 and over. There are current vaccine trials that are looking at those between 5 to 12, and I believe a few that's looking at below 5. But as of right now, vaccines are only available for those above the age of 12. So our younger pediatric friends, they don't really have much besides mask wearing that can help them out. And as this year, the school academic year is already underway, but as it began, a lot of schools, local counties, parishes, state governors had issued mandatory masks in schools. So we wanted to take a deep dive into what evidence was out there. So the objective of our study was to review the current literature and any of the data that is used to support facial masks in children that would mitigate viral spread. As we are all familiar, international, national, and state public health and professional societies have released many policy statements that support the use of masks in school. However, we didn't see any evidence that was cited on. So like I said, we really wanted to look at a deep dive into it. And what we initially saw before we even looked at any of the literature was that a lot of the guidance that we would see on the news that we would see from these professional societies really looked at adults. We didn't see any that was geared specifically for children. And so the method is what we did a literature search that looked at studies of adolescent mask wearing with regards to respiratory disease transmission with and without specific regard to the novel coronavirus. We looked at PubMed and Cochrane Library for results. We used terms COVID-19, face mask, SARS-CoV-2, surgical mask, children and adolescents to screen through some of the literature. And studies that looked at respiratory diseases and mask wearing were specifically selected. And we decided to exclude any editorials. A lot of the most recent literature out there is editorial in nature, so letters to the editor, responses to other people's publications, policy statements, position statements, and any non-research-based articles were excluded. And when we were looking at this, coming from a background of people that really understand anesthesia, anesthesiologists have a really fine understanding of the importance of mask fit and the importance of oxygenation. So we wanted to see what was out there. And unfortunately, we did not find much. So current research is actually pretty scant. There were only 3 studies, one from 2019 and 2020, that looked at other respiratory, the physiological effects of mask wearing, and then a 2021 study that was done with COVID in mind, but was not COVID specific. And the general gist of them, the first one had about 105 children wearing N95 masks that they did 5 minutes of activity, followed by 5 minutes of rest. And it looked at respiratory rate, heart rate, pulse saturated oxygen. And it showed no difference between the levels with wearing the N95 and without. There was a small study in Korea that did about, I believe, 24 or 25 participants that had a surgical mask, and it measured the same variables. And then there was the third one from 2021 was done in Italy with about 45, 46, I believe, 10-year-olds. And it had them do a 3-minute walk test that also looked at those variables and assess comfort for them. None of the trials, none of those published results showed any harm from wearing a mask at all. And what we saw was that the data, again, was just mainly from adults, largely drawn from the research that was done in the older population and then applied it to a pediatric and adolescent population. And while we know that from case studies that look at outbreaks at preschools, that look at outbreaks among daycares, that those who wore masks were less likely to contract COVID. Again, it wasn't looking at the effectiveness of the masks itself, because there's a wide variation in what masks the children were wearing. For instance, you just have to have a face covering in most of these situations. Children are not universally wearing N95s. They're wearing, surgical masks, procedural masks, or even bandanas, homemade. So there's a wide variability in, the effectiveness of the mask wearing, just because of the variables in mask form, fit, and quality. So in conclusion, as pretty much every good report says, further studies are needed. I believe that our pediatric friends deserve research that is specifically geared toward their cohort. Our health organizations and our professional societies, kind of like what we're saying at the beginning of the night, how we can be active in advocating for our patients. I believe that as physicians, we should seek out and encourage pediatric geared research. We have a lot of recommendations right now that have different types of masks. There should be more access to a universal mask that can give parents better reassurance. And one thing that I found particularly interesting in this brief study was that N95s themselves are not made for children. They're only made for adults. They're only approved for adults. They're only tested in adults, which makes sense. For instance, OSHA, which would approve a lot of masks that are seen in the workforce. Well, children aren't in the workforce, so that's why they don't have a specific approved mask that could be used for them. So if we go forward and seek out and advocate for pediatric-centered research, we can make evidence-informed decisions that are not only going to be better for our patients, particularly our pediatric patients, but when it comes to making recommendations, we can actually assuage some of the concerns that their parents are having. So thank you very much.
Well, thank you. I know we are always saying that we need to do more research. How are you going to talk mothers into having their children wear masks, as part of a research study?
Well, that's one of the things with, ethically, we can't have ideally, if you want to see if masks work in children, let's expose them to a virus, put half of them in masks and half of them not, and let's see what happens. But no one would ever do that, and nor would I ever advocate for that to happen. We just have to, at this point, extrapolate. But you're absolutely right. It's, no one wants to sign up their child for a potentially risky experiment. I think that if we had masks that are specific for children and smaller variables, for instance, When we oxygenate, we have in our pediatric population, we have masks that are, bigger than a silver dollar. We don't have neonatal N95s. We don't have a size N95 for a preschooler. The best fit that we have are the duckbill masks, but even then, those are very uncomfortable. So I doubt that they would want to keep them on there. But to get children to wear masks, I think that a lot of it comes from social cues. For instance, we know among kids that have type 1 diabetes, if you want to increase the adherence to a diabetic regimen with taking insulin, with checking your blood sugar, one of the best ways to encourage that adherence is actually have that child be in a friend group with other kids who have diabetes. That way they can see that this is a normal activity. So I think a lot of it comes from just parents, teachers, demonstrating that action for children. At the beginning, if you have a 3-year-old that you need to teach to put socks and shoes on every day is going to fight, until they get used to normalize to putting on socks and shoes every day. I think for the time being, if we, normalize continued mask wearing, then it just becomes a part of the day-to-day activity, and that can help decrease the viral spread among the pediatric population.
Good points. Good points.
So very interesting. There were many days in my adolescence I wish I was wearing a mask. I was also disappointed I didn't see any Twitter, Instagram, or Facebook references in your presentation. So shame on you. And then finally, seriously, our pediatric colleagues, one of the things that's interesting is RSV and how RSV was completely changed over the past 20 months from its typical seasonal variants because of isolation and mask wearing. So our pediatric colleagues were quite caught off guard with this very unusual summer RSV that they just went through. So there's something in that, obviously, that these kids were protected via isolation and somewhat mask wearing from something that is typically very seasonally specific, RSV. So I thought it was interesting there, but good presentation.
Right, and particularly with RSV, I remember Louisiana, we see it, it's a winter associated virus. This was back in, I want to say the end of February this year, that Louisiana had gone, I believe, about the first week of December to the last week of February without a single case of RSV reported to the LDH. However, in that gap that we had between the third wave and COVID, when we started, it was a summer, people going out more, we had that, really, really odd summer spike of RSV that, which I think was associated more to decreased mask wearing and people returning back to congregate settings.
Yes. Okay, Janet, now can I give you accolades? Thank you very, very much for everyone attending this evening. It just goes to show you that small meetings can be very informative. And we had some excellent presentations this evening. I know I learned a lot, and I hope everyone else did the same. And we look forward to next year. Again, Jay, thank you.
Yes.
Yes, indeed. And I want to thank Dr. Bobby, Dr. Eagleton, Dr. Kovaleski, any of the other staff that stayed on and have been able to attend.
Yes.
Huge thanks to Jana, Dr. Kovaleski as well. And of course, the master of masters of ceremony here, Dr. Bobby Nossman, who's been doing this a long time and does a fantastic job and is very underappreciated for this. So he knows he has my appreciation. He always has. I've known him since I was a med student doing a 2-lane rotation, and Dr. Nossman was here as staff. So fantastic job. And the other thing I wanted to point out is there were a lot of smiles here tonight. You can actually present information and cool scientific stuff and have fun with it. So you did a great job of doing that and having fun. Make that contagious, because you now have to pass that on, because the people right behind you are considering you a leader. You're their near peer mentor, and explain, hey, this wasn't so bad. Dr. Nossman doesn't bite too hard. Dr. Eagleton barely throws things at the screen. Dr. Zrahi is very good with getting folks going. So this can be fun, and we continue to do this. We build on the scientific advance for this field. So stay involved and keep it up. Thank you. I know, I'm sure our police support ASA pack there. And Dr. Izrahi or Dr. Eagleton, any comments, feel free.
Absolutely, Dr. Lanzak, Dr. Nels, everyone, thank you so much for giving the opportunity to our esteemed residents and medical students to present their hard work. This is a wonderful event, and as I said, you nailed it. This is a casual meeting, but at the same time, I would say this is one of the most productive meetings that I've ever seen, because you can learn from each other, you can discuss novel and interesting topics.
I agree. All right, Jana, why don't you just close this on out? Thank you again.
Thank
Appreciate
you.
it very much.
Good night.
Good night, everyone.
I know.